Hey everyone, and welcome to this explainer. Look, if you're an emergency physician, you already know that acute appendicitis is literally one of the most common surgical emergencies you're going to face on any given shift. But, the way we manage it, it's evolved massively over the last decade. So today, we're diving straight into an evidence-based clinical update, specifically curated just for adult emergency care. We're drawing heavily on the highly anticipated 2025 and 2026 updates to the WSES, that's the World Society of Emergency Surgery Jerusalem Guidelines. And just to be clear, right up front, we are stripping away all the pediatric and obstetric stuff today to focus purely on that standard adult patient sitting right in front of you. Let's get into it.
So, is surgery still mandatory for uncomplicated appendicitis? Well, for literally over a century, the answer to that was just an automatic, resounding yes, right? You found appendicitis, you called your surgical consult, and the patient went straight to the OR. Simple as that. But the absolute latest evidence is really forcing us to challenge that whole traditional paradigm. Because as we'll see in the data, for a very specific subset of patients, antibiotics alone might actually be enough. The catch here? Your patient selection has to be flawless.
Here's our quick roadmap for this explainer, so we can lock in the high-yield stuff. We'll start with the diagnostic challenge, move into clinical risk scoring using the AR score, compare our imaging modalities, build an integrated management algorithm, and finish up with key clinical takeaways you can actually use on your very next shift.
All right, Section 1, the diagnostic challenge. Moving right along to Section 2, clinical risk scoring using the AIR score.
Okay, so accurately telling the difference between uncomplicated and complicated cases is now, without a doubt, the single most critical step in your workflow. If it's complicated, there's a perforation, an abscess, phlegmon, or diffuse peritonitis, the pathway is obvious, surgery. But if it's uncomplicated, well, a whole new world of non-operative management suddenly opens up to us. To actually stratify these adult patients properly, the WSES Jerusalem Guidelines recommend totally moving past older tools, like the Alvarado score, and instead adopting the ARS score, the Appendicitis Inflammatory Response score. This was explicitly built to overcome the flaws of those older systems by actually grading the severity of inflammatory markers and clinical signs. You get 1 point for vomiting, 1 point for right iliac fossa pain, and 1 point for a fever over 38.5 Celsius. But look at how it handles the more objective signs. Rebound tenderness can actually score between 1 and 3 points depending on if it's light, medium, or strong. Polymorphonuclear leukocytes give you 1 point if they're 70 to 84% and 2 points if they hit 85% or higher. You see a really similar graded scoring for total white blood cell count and serum CRP too. It's exactly this level of granularity that makes it such an incredibly powerful tool in the adult ER.
Now, how do these numbers actually help you? Well, these cutoffs translate directly to your diagnostic confidence. If you use a cutoff score of 5, the AIR score gives you a fantastic sensitivity of 92%, meaning it's a stellar rule-out threshold. If your patient scores below a 5, appendicitis is highly, highly unlikely. On the flip side, if you use a cutoff of 8, your specificity absolutely skyrockets to 97%. A score of 8 or higher basically means you're ruling in appendicitis, which sets you right up for the next crucial step.
Section 3. Imaging modalities, CT versus ultrasound.
All right, once your clinical suspicion is dialed up by that AIR score, you need imaging to confirm the diagnosis and critically to rule out complicated disease. So how do our imaging options actually stack up when we're assessing their sensibility for adult patients? Ultrasound is great because it's non-ionizing. You avoid radiation. But as we all know, it is heavily operator dependent. And in adults, especially anyone with a higher BMI, it's pretty frequently just an inconclusive first step. Now, MRI, on the other hand, boasts fantastic sensitivity and specificity, again with zero radiation. But let's be real about the fast-paced ER environment for a second. MRI is super expensive, it takes way too long, and is generally just logistically impractical for acute adult abdominal pain. So that leaves us with the CT scan. According to the updated WSES guidelines, CT is unequivocally the gold standard. It is the most accurate imaging modality for adult appendicitis, period. It gives you high sensitivity and specificity, it accurately measures appendicular wall thickening greater than 6 millimeters, and most importantly, it easily spots extraluminal air, abscesses, and appendiculus.
Take a look at this scan. Notice that hyperdense, bright intraluminal calcification marked right there in the right lower quadrant? Yeah, that's an appendicolith. And finding this is no longer just some neat little radiologic footnote for your chart. It's a literal fork in the road for your entire treatment plan.
Because here is the absolutely crucial point. The presence of an appendiculus is a major, heavily validated predictor of non-operative treatment failure.
And honestly, the pathophysiology makes perfect sense, right? You've got an obstructing calcified stone, it cranks up the intraluminal pressure, it cuts off mucosa blood flow, and it just acts as this perfect little nidus for bacterial proliferation that IV antibiotics simply cannot penetrate effectively. If you try to manage an adult patient who has an appendiculate using just antibiotics, they are looking at significantly higher rates of recurrence, readmission, and nasty complications down the line.
Section 4, the Integrated Management Algorithm.
But before we actually look at the algorithm itself, we really need to understand the data that built it. The landmark APEC trial and then the CODA trial that followed literally shook the surgical world. The APEC trial found that 70% of patients with uncomplicated appendicitis who were treated with antibiotics successfully avoided surgery at 1 year, which is massive, right? But we got to look at the long game. At 5 years, the cumulative recurrence rate in that exact same antibiotic group was 39%. So what does that mean? While antibiotics are definitely non-inferior in the short term, realistically, almost 4 out of 10 of these patients will eventually end up needing that appendectomy anyway.
And that brings us to the WSES management algorithm, which brilliantly integrates your clinical evaluation right alongside the CT findings. Obviously, if the imaging shows complicated appendicitis, like generalized peritonitis or localized abscess, surgery or drainage is mandatory. But let's follow that pathway right down the middle. If it's uncomplicated appendicitis, the very next decision note is simply asking, is there an appendiculith present?
Let's break this down into 3 totally manageable cognitive steps for your practice. Step 1. Use your CT scan to confirm, beyond a doubt, that the appendicitis is purely uncomplicated. Step 2. Aggressively hunt for an appendicolith on that scan. Step 3. If you see an appendicolith, direct that patient straight toward a laparoscopic appendectomy. The risk of antibiotic failure is just way too high. But if there is no appendicolith, well, now you actually have 2 truly viable options to discuss with the patient: the standard laparoscopic appendectomy or trying an antibiotic-first approach.
Section 5. Key clinical takeaways from the WSES 2026 guidelines.
Okay, let's wrap this up. What are the high-yield, practice-changing points you absolutely need to take home from these 2025 and 2026 updates? Number 1. CT is unequivocally the most accurate imaging modality for standard adult patients. Rely on it. Number 2. Laparoscopic appendectomy is still the definitive standard of care. It offers low complications and practically zero recurrence. Number 3. The antibiotic-first approach is highly viable now, but only for very carefully selected uncomplicated cases. Number 4. If you spot an appendiculith on that CT, antibiotics are probably going to fail, so lean heavily towards surgery. And number 5, which is actually a super helpful operational update, if you do opt for surgery in an uncomplicated case, the guidelines now explicitly state it's safe to delay that appendectomy for up to 24 hours without spiking the risk of adverse outcomes, which, let's be honest, is fantastic news for overnight ER flow.
I want to leave you with this final thought. Management is no longer just the strict, thoughtless algorithm that leads blindly to the OR. It's become a highly nuanced discussion. When you have an adult patient sitting there with uncomplicated appendicolith-free appendicitis, you now have to sit down and honestly explain that yes, they can avoid surgery today, but they're carrying a 39% risk of recurrence over the next 5 years. How are you going to navigate that conversation at 3 a.m. on your next shift? Shared decision-making is officially the new frontier of emergency surgical care. Thanks so much for joining me for this explainer, and I'll catch you on the next one.